I am Shahana A Choudhury. I'm a professor of pediatrics at Meharry Medical College, Nashville, Tennessee, in USA. I'm honored to present my talk today at the SciTech Virtual Conference, November 23rd, 2020. My title of my talk is Seroprevalence of Antibodies to Tetanus Toxoid and Diphtheria Toxoid in Perinatally Human Immunodeficiency Virus-Infected Children and Adolescents. Routine childhood vaccinations. Routine childhood vaccinations are an important aspect of all well child visits. The purpose is to prevent vaccine-preventable diseases in children, and the ultimate goal is to eliminate vaccine-preventable diseases in children globally. There are some concerns in this era of COVID-19 pandemic, and the importance of routine childhood vaccination is underscored. Children remain at risk for non-compliance with well child visits and routine childhood vaccinations during this COVID-19 pandemic globally. Concerns remain for a resurgence of forgotten infectious diseases of the past. And why are routine childhood vaccinations more important in HIV-infected children? Because studies have suggested that these children not only have suboptimal coverage rates for routine childhood vaccinations, reference 1 to 2 as below, but also have suboptimal immunity to vaccine-preventable diseases when compared to their uninfected counterparts, references 3 to 4 as below, despite adequate vaccinations. Even in the era of highly active antiretroviral therapy, heart therapy, HIV-infected individuals remain at a higher risk of complications from vaccine-preventable diseases than their uninfected counterparts. HIV-infected children and adolescents with disease progression in particular, either clinical or immunological disease progression, also warrant close monitoring in terms of timing of vaccination, number of doses, and booster doses of the vaccines. It is also important to monitor protective immune status in these children and adolescents. Forgotten vaccine-preventable diseases are tetanus and diphtheria. Tetanus and diphtheria had almost been eliminated from most parts of the high and middle-income countries due to routine vaccination of children globally. Resurgence of these diseases may remain a concern during this COVID-19 pandemic. The vaccine-preventable disease tetanus. Tetanus is a life-threatening but preventable disease. In healthy individuals, the disease primarily occurs in unvaccinated or inadequately vaccinated individuals. Incidence of tetanus has decreased substantially due to a routine vaccination program for all children and adults. Incidence and prevalence in the United States is rare. Tetanus cases in the United States only occur in the unimmunized or in the elderly, and that is this due to waning immunity. Worldwide, tetanus is a rare disease of the underdeveloped world. It occurs more commonly in areas where the soil is cultivated and in warm climates. More frequently seen in neonates and children in the countries where there is no immunization program in place. The case fatality rate, according to World Health Organization, estimates worldwide tetanus deaths in 1997 at around 275,000 and improved rates in 2011 at 14,132 cases only. Now, the forgotten vaccine-preventable disease, diphtheria. Diphtheria is a potentially severe illness. Among unvaccinated persons, the case fatality rate may be 5% to 10%, even with appropriate treatment. During 1990 to 1995, approximately 4,000 deaths had resulted from the ongoing diphtheria epidemic in the former Soviet Union. In the United States, respiratory diphtheria is rare. Only 41 cases had been reported over a 15-year period from 1980 to 1995. A recent case of respiratory diphtheria caused by a toxin-producing strain of Corynebacterium ulcerans was reported in a resident of Indiana in 1996, reference below. Diphtheria continues. Concerns remain for a potential resurgence of diphtheria globally, for even in countries with long-standing immunization programs. The basis for this concern is the reemergence of a recent epidemic of diphtheria in the newly independent states of the former Soviet Union in the 1990s. In the United States, there is a potential setting exists in which diphtheria could spread because of the large population of susceptible individuals, the immunocompromised and the elderly. According to ACIP recommendations, which is the Advisory Committee on Immunization Practices in the United States, infants and young children are recommended to receive a 5-dose series of diphtheria and tetanus toxoids and acellular pertussis vaccines, DTaP, with one adolescent booster dose of tetanus toxoid, reduced diphtheria toxoid, and acellular pertussis, Tdap vaccine. The revised objective for this study in the era of COVID-19 pandemic. The original study was performed several years ago. It is important to revisit the data in the era of COVID-19 pandemic in order to underscore the importance of timely immunization of all children, particularly those who are HIV infected. And to re-emphasize the fact that toxigenic strains of Corynebacterium diphtheria, and Corynebacterium ulcerans and COVID-19 share a common route for transmission, that is the respiratory droplets. The methods for the original study was conducted between August 1995 and April 1997 following approval of the protocol by the Ethics Committee of the institution located in Brooklyn, New York. Study was performed as part of routine standard of care. The data is revisited now in this era of COVID-19 to re-emphasize the fact that HIV-infected children and adolescents remain at risk for resurgence of these vaccine-preventable diseases. The study population consisted of an HIV group and a control group of children who are HIV uninfected. A convenient sample of 24 HIV-infected children was selected from the Pediatric Infectious Disease Clinic. All HIV-infected children had vertically transmitted HIV from their mothers. 15 children had received 4 doses of the DPT vaccine, and 14 children had received 5 doses. 5 of the 4-dose recipients enrolled a second time into the study as a 5-dose recipients as the study continued prospectively. All HIV-infected children were on monotherapy or on combination antiretroviral therapy. Evidence of moderate to severe clinical disease, according to Centers for Disease Control and Prevention, that is CDC, Class B and C prevailed in 65% of the children, and moderate to severe immunological disease, that is CD4 count below 15% for age, prevailed in 52%. None of the children had received intravenous immunoglobulin at any time during the study. HIV-related information, which consisted of HIV testing results, antiretroviral therapy, B and C, T cell and B cell count, viral loads, was obtained from the patient's medical records. The study population HIV group, children who received 4 doses and children who received 5 doses of the vaccine. There was no significant difference between these children, 4 doses or 5 doses, in terms of CD4 counts, viral loads, or CDC clinical category. The control population consisted of 20 children, 9 in the 4-dose group and 11 in the 5-dose group, whose mothers were HIV seronegative and were recruited from the general pediatric clinic as the control group. Control children were matched approximately by the number of doses of the vaccine and not by their ages. Vaccination and laboratory evaluation consisted of the primary series and the booster doses. The primary series of the vaccination consisted of 3 doses of adsorbed DPT, diphtheria, tetanus, toxoid, pertussis, manufactured Connor Laboratories, or tetramune, diphtheria, tetanus, toxoid, pertussis, Haemophilus influenza type B, manufactured laterally white. The booster doses consisted of the 4th and 5th doses as routine boosters, administered at age 12 months or over 12 months, but under 84 months or 7 years, as DPT or tetramune, except one HIV-infected adolescent, 98 months of age, who received big T small d vaccine, TD vaccine, as his 5th dose. Baseline antibody, the anti-TT and anti-DT IgG, was assayed using an enzyme-linked immunosorbent assay ELISA performed in the Specialty Laboratory, Santa Monica, California. The protective antibody level was defined as a level of greater than 0.1 international unit per ml for both anti-TT and anti-DT, and considered a correlate of protection. Follow-up antibody was applied to only HIV-infected children. 14 HIV-infected children, 6 from the 4-dose group and 8 from the 5-dose group, had a follow-up antibody level evaluated after a mean of 10 months, ranged 2 to 7 months from the baseline antibody evaluation. Age in months at vaccination in the 4-dose recipients between the HIV positive and HIV negative groups, there was no significant difference. However, age in months at vaccination in the 5-dose recipients between the HIV positive and the HIV negative groups, there was a significant difference of 0.02. HIV-infected children happened to be significantly older, 70 months, and HIV-negative children happened to be 54 months mean age, with the range for the HIV positive being 34 to 84 months, HIV negative children 49 to 66 months. The rest of the data, mean age at serology, or mean age or mean interval between vaccination to serology, was not significant for either the 4-dose recipients or the 5-dose recipients. Anti-TT and anti-DT antibodies and HIV-infected and infected children. There was no significant difference for anti-TT antibodies, either in the 4-dose or the 5-dose recipients between the HIV-infected and HIV-uninfected children in terms of antibody levels. 0.91. However, there was significant difference noted in the antibody levels for anti-DT between the HIV-infected and HIV-uninfected children for both the 4-dose recipients and 5-dose recipients. The p-values being very significant, highly significant at 0.004 and 0.007. This slide is a graphic representation of anti-TT tetanus antibody levels in HIV-infected, HIV-uninfected children. There is no significant difference noted in either the 4-dose recipients or the 5-dose recipients. However, there was a substantial decrease in the anti-tetanus toxoid antibody levels in the HIV-infected children in the 5-dose recipients only, compared to the HIV-uninfected children. This is a graphic representation of the previous slide for anti-DT antibodies in HIV-infected versus HIV-uninfected children. And there is significant difference between the HIV-infected and the HIV-uninfected children in the 4-dose recipients as well as the HIV-infected, HIV-uninfected, and in the 5-dose recipients. P-values being highly significant at 0.004 and 0.007. The prevalence of protective immunity to tetanus toxoid and diphtheria toxoid, regardless of the antibody levels. Protective immunity is another aspect of immune status evaluation. The protective immunity is defined as a level greater than 0.1 IU per ml and for tetanus toxoid as well as for diphtheria toxoid. The proportion of children that were immune to tetanus toxoid was comparable in the 4-dose recipients for tetanus toxoid. Immunity 73% HIV-infected, 100% of HIV-uninfected children. However, in the 5-dose recipients, the tetanus toxoid immunity prevailed in only 57% and 100% in HIV-uninfected. The protective immunity for diphtheria toxoid in the 4-dose recipients in the HIV-infected group prevailed in 60% and 100% of the HIV-uninfected group with a p-value of 0.05. In case of the 5-dose recipients, 57% of the HIV-infected children, 100% of the HIV-uninfected children were immune to diphtheria toxoid, p-value being at 0.02. The waning immunity was determined for tetanus toxoid and diphtheria toxoid in only the HIV-infected children. Their antibody levels were followed up after a mean of 10 months. For tetanus toxoid, the baseline antibody of 1.11 mean antibody level, anti-TT declined to 0.65. That is 46% declination. However, the p-value was not significant. For DT, the antibody level declined from 0.73 minimally to 0.60, declination calculated at 13% only, not significant. Now, our discussion and conclusion. In our study, non-compliance with timely routine vaccination is noted in HIV-infected children. They were significantly older than their uninfected counterparts. This reinforces existing data in the literature. Our study has demonstrated that immunity to tetanus toxoid and diphtheria toxoid in HIV-infected children, adolescents is suboptimal, despite adequate number of doses of the vaccines when compared to the uninfected counterparts. This raises enormous concerns in this era of COVID-19 pandemic for a heightened risk for resurgence of tetanus and diphtheria that may disproportionately affect the HIV-infected pediatric population. Although antibody levels to tetanus toxoid were comparable in HIV-infected and uninfected children, the prevalence of protective immunity was significantly lower in the older children, that is the 5-dose age group. This highlights the importance of timely immunization at a younger age. Indeed, the levels were significantly lower for diphtheria toxoid. And in both the 4-dose and the 5-dose age groups. A substantial decline in follow-up anti-tetanus toxoid level from baseline was observed, which may suggest waning immunity non-protective levels may occur in older adolescents and young adults, concerning for whether booster dose of the Tdap at 11 years of age is available in low-income countries or not. In this context, concern should also remain for HIV-infected women with inadequate immunity to tetanus are at risk of developing tetanus and tetanus in their newborns before acquisition of vaccine-mediated protection, even in the high-income countries. The heightened concerns may remain for resurgence of diphtheria, in particular during the COVID-19 pandemic, due to a common mode of transmission, respiratory droplets for both the pathogens. It yet remains to be determined if transmission of toxigenic strains of Corynebacteriaceae may be promoted with underlying COVID-19 infection in HIV-infected children and adolescents. We therefore voice with the American Academy of Pediatrics and strongly recommend developing strategies within the scope of all pediatric practices globally to keep up with timely vaccination of all children and adolescents, particularly the immunocompromised population, in this era of COVID-19 pandemic. This brings my talk to an end, and thank you very much for your attention.